now going to invite Dr. Brequelle Timothy. She's a consultant obstetrician and gynecologist at Sangre Grande Hospital with interest in reproductive medicine and is an associate lecturer at the University of the West Indies. Dr. Timothy is going to lead some local case discussions with input from our expert panel.
Hi, good evening, everyone. I know it's late and we're a bit tired, so I'll try to be quick about it. But for our panel, I just want to start by letting you know about the hospital I work in. I work at Sangre Grande Hospital, and we serve a relatively rural community. We're about the second smallest delivery hospital. We have about 1,300 to 1,500 deliveries per year. We are just one unit with 3 consultants. This is a general obstetrician gynecologist consultants, about 6 registrars and 10 house officers. We, about 2 years ago, started, again, because of our, that we're in a rural area, we realized that a lot of patients were having, particularly high-risk ones, difficulties coming into the high-risk antenatal clinic. So we started an outpatient specialist service where our registrars, of course, with our advice, would go out and do clinics in the communities. Last year, we also started a nice little database, a high-risk obstetric database to which everybody has access. So, for instance, if you go on vacation, it's very easy when you come back out to know what's happening, especially with the high-risk cases. Because we're so small, we're able to have weekly perinatal meetings, so all our high-risk cases are discussed there, and we also, do risk assessment for past cases. We have a Level 2 NICU, just about 3 beds, so which means that most of our elective preterm deliveries, less than 32 weeks, gestational age and less, birth weight less than 800 grams, or of course any severe congenital abnormalities that likely will need neonatal intervention, we have to refer to the centers that I think Dr. Prasad would have told you, our 3 referral centers. So this was supposed to be interactive, but I know it's late, so I'm just going to get right on to it. This first case I'm going to present, there's no teaching. I'm not a maternal medicine specialist, so I'm going to rely on the panel for this case discussion. She's a lady, she's home having pain, and then she's like, oh, I missed my period. And did a UPT, of course, it was positive, else I wouldn't be presenting her, right? She was having this severe low abdominal pain, and she's like, I'm pregnant, let me go to my obstetrician. By the time she got to the obstetrician, he confirmed the intrauterine pregnancy about 8 weeks. She was having really bad abdominal pain, hematuria, dysuria, so of course urinary tract infection was diagnosed. That first culture grew group B strep, so not your usual suspects of E. coli and Klebsiella, which is one indicator there. And he treated her at first with nitrofurantoin. Over the course of several weeks, she kept on having symptoms, particularly frank, really bad hematuria. And then by the 3rd infection, he was like, you know what, this is sounding very serious. Let me refer her to nephrology. So she saw a nephrologist privately, and he then admitted her to hospital, because when he did his blood investigations, he found that she had a serum creatinine of 5.2. That's in milligrams per deciliter. So that, I don't know if you'll use micromoles. So that's about 4. So that's like 400. It's high, okay? Yes. I think we could all agree that it's high, even for a non-pregnant patient. I know the professor gave us all the lecture about the physiological changes in pregnancy. So for a normal person, this is high. For a pregnant person, it's really high, right? When they did an ultrasound, they found an atrophic left kidney. The right kidney looked okay, but there was some non-obstructing calculi there. And so the nephrologist says that this is stage 5 renal disease. So like I said, she was admitted to the ward, so she's about 15 or so weeks. She got IV antibiotics for that infection that she had. She also had a chronic anemia, well, we assume it's chronic, right? Because her HB was 7.9 or 79, depending on the units. And she was diagnosed with gestational diabetes, just based on a fasting of 94, right? She couldn't do an OGTT, she vomited up, she was sick. In terms of her antenatal course, about a week later, she started dialysis on the ward, and she had to get it 6 times per week. Her HB dropped at around 17 weeks to 6 grams, so she got one blood transfusion. Thankfully, like I said, the fasting wasn't that high, so her gestational diabetes was well controlled with diet alone. She was going fine, surprisingly, with her blood pressures until about 20 weeks when she developed really bad hypertension, as to be expected. So she started off on like nifedipine, 20 BD and labetalol, and then had to increase to 20 TDS. We had to switch to hydralazine because we don't have labetalol. There's problems with supply, so they had to switch to hydralazine because of availability. Surprisingly, after that first course of IV antibiotics, her monthly urine cultures showed no bacterial growth. And like I said, because we have monthly, her scan was normal and she had growth scans, about 3 of them from 26 weeks, and they all showed good growth of baby, normal umbilical artery Dopplers. And she was discussed very frequently in our perinatal meetings, obviously. As I mentioned before, this is somebody who preterm labor is likely, but in her case, we made the decision that it would not be wise to transfer her for maternal reasons. This was somebody on dialysis 6 times, only on Sundays was her break day. So we thought that transferring her would actually impair her dialysis treatment, and the peds agreed with us, and they said that they would transfer ex utero if push came to shove. So let me stop. Any questions? I mean, I purposely did not put too much information in case you guys had questions, comments, or predictions on outcome.
I'm not going to predict the outcome, but I'm just interested whether you gave termination of pregnancy as an option when you found out her CKD was so bad.
At 15 weeks is when they diagnosed it, and no one. Generally, it's very hard. Dr. Surchison could comment on that, to offer termination in our setting, especially at 15 weeks. Yeah.
And was she told that establishing her on dialysis now meant she would be on dialysis forever?
Yeah, correct. So we don't have a diagnosis, by the way, as in there's no kidney biopsy or anything like that.
You can't kidney biopsy her because she's only got one kidney and it's got a stone in it, and that's way too dangerous.
Yeah. So are you saying that there are no termination services at all available?
Dr. Surchison, you want to take that? No, seriously?
So basically, there are certain circumstances within our laws that allows it, but it for most purposes, it's considered a criminal act. But there are certain circumstances, again, similar terminology as in UK law, and it is allowable under certain circumstances. But it would have meant doctor in discussing with other consultants through the bureaucracy and so on to justify it.
And my other question is, did you give her low-dose aspirin to...
Yes, sorry. Yes, I purposely left that out to see if anybody would ask. Yes, she was started on low-dose aspirin. Any predictions? You saying something?
No. If I'm so super impressed that you were able to offer her dialysis 6 times a week. That is like, oh my gosh.
One of the advantages that we have, even though we're a small hospital, services are going to be a bit better.
But that's so impressive. And because you've done that, we would have given her EPO rather than transfuse her because her kidneys won't be producing it. But because you're dialyzing her regularly, you might prevent preterm delivery in the same way that we would have expected with CKD4/5 before the before the advice changed to regularly dialyze little and often, which is what you've done. That will avoid fluctuations in fluid, which is probably what used to set off preterm labor in the olden days when we just used to dialyze them 3 times a week. So I predict this woman is actually going to get beyond 34 weeks. I predict she's going to get preeclampsia. And I predict that's going to be hard to diagnose. And I predict she's alive and well because you only had 1 maternal death in Trinidad last year.
Yes. Oh, yeah. So she was in November, and I mentioned November last year. So, sorry. Slides, please. Thank you. So she was admitted at 32 weeks with severe hypertension. We tried really hard to give IV meds, IV labetalol. We have IV labetalol. And She got enough time to get dexamethasone, and about 4 days later, after admission, she got an elective cesarean section with a birth weight of 1.4, which is actually pretty okay for 32 weeks. Baby is well. We were able to keep an arm in the NICU, so they were proud of that because baby was basically a feed and grow. She was discharged, still on a lot of antihypertensive. Now, obviously, she's no longer pregnant. She's on dialysis 3 times per week, and she got her subdermal implant for contraception. Right, I'll just move on quickly to the next case. Sorry, are there any questions about that first case? No? Good.
Because at that time they didn't have IV Brequelle.
Yeah. Thank you.
I was listening to you.
Yes, you were. I was like, wow, somebody was listening, yes. So the second case is that of a 36-year-old gravid of 4, para 1 plus 2, first seen at our antenatal clinic at 21 plus 3. She had a history in 2008. She had 3 pregnancies. Fortunately, 2 of them were miscarriages, and 1 of them was a preterm delivery at 32 weeks. She was well known to us and the medical clinic because she was hypothyroid, having had a total thyroidectomy in 2009 for medullary cancer. So she was on all-thyroxine 200 micrograms, and her TSH on the first visit there was 46, with a total T3 of 0.5 and T4 of 2.6, so still very hypo. Of note, she had a LETS in 2017 for CIN3, and that was completely cleared. I put there in 2019 she had a query and STEMI because this was a big topic of debate. She had chest pain, palpitations, but when they did the ECG, just mild ST depression. Her coronary artery angiogram was normal. Her echo was normal. And so the medical team had their own debate about what was causing her symptoms. But she was in their clinic because of the hypothyroidism anyway. So when she was seen, she was jointly seen, so she's being seen in our clinic and the medical clinic. They increased her L-thyroxine. They were of the opinion that, she had no symptoms whatsoever, so she was New York Heart Association Class 1. They didn't think that she needed any further cardiac investigations. So in terms of our management, our contribution really was just vaginal progesterone until 34 weeks because of her preterm delivery. She also as well had a anomaly scan and monthly growth scans. This was the other piece of contention in that, so we don't have we have regular nephrologists, we have regular neurologists, but we don't have a regular cardiologist. They have a clinic, I think, once or twice per week. And so the big debate was, this woman is asymptomatic, and then the cardiologist says, well, she had really high elevated troponins in 2019. Yes, the angiogram was normal, but that doesn't rule out heart issues, and she may not be able to tolerate labor. Yes, so I know. But yes, so that is what it was. Do you want to, yeah, we can stop now. I know you want to say something. Yeah.
My heart sinks when I see this because I know that, why wasn't she delivered at 39 weeks?
Yeah.
Why didn't she have a vaginal delivery?
Yeah.
In fact, you didn't have to.
Cardiologists tell you what to do.
In fact, there wasn't any reason to offer delivery until her due date or post date, offer induction of labor and vaginal delivery.
I agree with you totally.
And if she wants a cesarean section, you do it between 39 and 40 weeks.
But I think, on a serious note, what cardiologists and most physicians don't understand is that an elective cesarean section is a major physiological insult. It's a much higher risk of hemorrhage, thrombosis, infection. And if she had ischemic heart disease, the cesarean section is way more dangerous than a vaginal delivery. And it's up to obstetricians to say to the cardiologist, no, I'm going to deliver her vaginally. You tell me if you think she's got ischemic heart disease. You tell me, but in fact, come and watch me do a cesarean section, then follow the woman for 3 days and see what the recovery is like. and then be recommending an operation that you know nothing about.
Thank you so much for saying that,
think-
Professor. My HOD is watching, and I am listening to what you're saying. Yes, because I was.
I think we are good at doing cesarean sections and we have good outcomes, but people still forget that cesarean section is a major operation and does carry risk. The risk of major hemorrhage, hysterectomy, placental creasel, poor placentation in the next pregnancy, risk of allergies in the baby, the child as they grow up, and stillborn in the next pregnancy. People forget these things. So cesarean section should only be done for the normal obstetric reasons and nothing else.
I agree. Yes. Oh, thank you.
Brequelle, I just had a quick question. Smoking history, drug history of this patient.
She negative. No smoking, no drugs, no.
Because it's quite possible that she did have an NSTEMI with clear coronary arteries. She may have had coronary artery vasospasm, usually associated with cocaine use and tobacco use. So it's quite possible that she does have underlying
That's a
ischemic
very
heart
good
disease.
point. Yeah. She was in the clinic, they're a patient for quite some time, and they didn't get that history. So, but yeah.
I just thought it's interesting because
I-
if we don't ask those specific questions, the only reason I know this is because it happened to me.
Right.
Clear ST elevation MI in a 36-year-old professional.
But she
athlete.
didn't have SC, that's what
I know,
you
I know.
debate here.
But in a 36-year-old professional athlete. And because the history wasn't so great by the house officer, the consultant on more inquiry realized that there was a history of cocaine use. So he had a confirmed MI with completely normal coronary arteries.
Right.
It's just
So, thank you, that's a very good point.
That might be true, and but the best stress for cardiac event is pregnancy, and she has gotten to 37 weeks completely asymptomatic, so I would have still waited.
I'm just saying it could explain the findings.
Oh, yes, yes.
No,
Yeah.
I've accepted that, yes.
And if you have a patient with a STEMI or an NSTEMI due to coronary spasm, either due to cocaine or just coronary artery vasospasm, the obstetricians need to know to avoid uterotonics that are potent vasoconstrictors like ergometrin, synthometrin. So it's actually, and we avoid those in most cardiac deliveries, whether they're delivered vaginally or by cesarean section. But just to be clear, even if she had a proven STEMI, Ingrid's opinion wouldn't change. She would still recommend vaginal delivery.
Yeah.
But also you have raised a very important point, is that as midwives and obstetricians, we are really poor at asking about drug history, even for our women, young women, or even older women who come in with massive abruptions for no apparent reason. We don't ask about cocaine use or other drug use, so that is a very good point.
Thank you. Any other comments, questions? No. We'll move on. So in terms of her outcome, so yes, we complied with the cardiologist's recommendation of elective delivery. So she was admitted on Saturday because we give dexamethasone to all our elective cesarean sections before 39 weeks. So she was admitted on a Saturday for steroids, planning for delivery the following Tuesday. On day 2, so that's Sunday morning, Monday morning, Sunday night. She started to complain of shortness of breath, chest pain, very unwell. Her blood pressure started to go through the roof. ABG, she had a lactic acidosis, hypokalemia. Her RBS was 504, so clearly somebody under a lot of stress. Of course, the crash team was called. This is the medical team, the anesthetic team. She was resuscitated. And they were planning for delivery, became unresponsive at 4 a.m. Oh, but prior to that, but we were able to get verbal consent for cesarean section. So when she became unresponsive, she was intubated and delivered and sent to theater. She subsequently had 6 days in the ICU, discharged okay, but the CTPA confirmed acute pulmonary embolism with pulmonary edema. She also had an acute ischemic infarct. And even though it was UK MEC2, we thought that the subdermal implant was still okay for her. Yeah. That's it.
So my questions are, so in the UK, we are now moving away from giving steroids beyond 34 weeks because of the impact on fetal brain development.
Even for elective cesareans.
Absolutely, not for, yeah.
Especially for
So,
elective cesarean section.
because we are first to do no harm. So, and the evidence is out there, and if you want us to provide you with the evidence on which we base this practice, we would be very happy to do that. The second thing I wanted to ask was, did she ever have an antiphospholipid or thrombophilia screen?
No. So, a little caveat with this case. We did have the opportunity for some pre-pregnancy planning because she was in our clinic for subfertility. She wanted an next baby. So she had, her partner had an essay that showed azoospermia, right? And we're very limited with fertility treatment in our setting. I think we got a bit complacent when we got the azoospermia, thinking that, yes, her thyroid is not controlled, but she's not going to get pregnant anytime soon. But she found a cheaper and more convenient method. So she left the clinic and came back to us pregnant, having changed partners. So that is, in terms of the medical doctors, I think everybody wasn't expecting her to get pregnant so soon, so she didn't have that.
At least she didn't order the sperm off the internet. Could they do that?
I'll just make a comment about the hypothyroidism because
Yes,
I think
please.
it's really important that people understand it. Most women who have hypothyroidism don't need more thyroxine in pregnancy, but the exception to that rule is women who've had thyroidectomies for cancer or women who've had radioiodine. And that, as her thyroid function illustrates, she was profoundly hypothyroid. And you could have predicted she needed more thyroxine early on in the pregnancy. But I wouldn't want any of the endocrinologists in the room to think that all pregnant women need more thyroxine because most of them actually don't. And fertility experts have a slightly irritating habit of telling women they all have to take more thyroxine because the TSH has to be less than 2.5. It only has to be less than the normal pregnancy range, which is less than 4 for most women, depending on your lab. But I know that around the world there is this
correct,
sort of, you're going to miscarry if your TSH isn't 1. And that's not true. I think it's very interesting that she's had a PE, maybe a PE and a stroke.
Yeah.
And that does raise the possibility, as Sonji says,
Yes,
of APS.
correct.
So the question in the back of my mind also is recent cancer diagnosis and treatment. Should she have been on low molecular weight heparin throughout the pregnancy?
The cancer diagnosis was in 2009.
Not within 5 years.
No.
So I got the first part of the question, but not the second part of the question. So you're absolutely right. With thyroid cancer, you want to suppress the TSH, and those are the patients who you give bigger doses to suppress.
Yeah, so she wasn't suppressed for a long time. We don't have the means publicly to monitor thyroglobulin and things to make sure there isn't any thyroid tissue anywhere. So how do we know that she didn't have recurrence of a medullary thyroid cancer that could have been causing also these problems with clotting and all these kinds of
I'm
things?
guessing with imaging, but I'm going to ask Melanie if she knows. To diagnose, or Professor T. Luk Singh to diagnose recurrence of medullary carcinoma of the thyroid.
So that's what I mean. We usually monitor the thyroglobulin and
Yes.
those kind of things, which we don't have the means to do that publicly in Trinidad. But that is something going forward that we should be looking into as well.
We were just wondering, in the setting of the medullary thyroid cancer and then the severe hypertension with the metabolic acidosis, whether you'd consider a FAO.
What?
Absolutely. As MEN1, so
MEN2.
she might have a fear, MEN2, she might have a pheochromocytoma in association with the medullary.
Yeah, I did see the medical people, write that as one of their differentials. I really did. I just didn't want to talk about it. Like I said, that's my specialty. Any other? That's it? Okay, thank you so much, everyone. It's a great news in the world.